The moment a patient walks out the hospital door after discharge, the clock starts ticking on whether they will come back. Modern healthcare delivers clinical excellence inside the hospital, but that effort often hits a wall as soon as the patient heads home. Take a look at this breakdown. Hospital readmissions cost Medicare $26 billion every single year. A single 30-day readmission averages $16,300. Across the United States, 3.8 million adult patients are readmitted annually. This volume reflects a breakdown in the transition of care, where the success of a hospital stay is disconnected from the patient's recovery at home. To force a change, the Centers for Medicare and Medicaid Services launched the Hospital Readmissions Reduction Program. Hospitals with higher than expected readmission rates face a Medicare payment penalty of up to 3%. This map highlights the footprint of those penalties. For fiscal year 2026, approximately 2,400 hospitals across the country face some level of payment reduction from CMS. For a large health system receiving hundreds of millions in annual Medicare payments, even a small 1% penalty translates directly to millions of dollars in lost revenue. Despite years of clinical quality improvement initiatives, the 30-day all-cause readmission rate held steady at 13.9 per 100 admissions between 2016 and 2020. The $26 billion annual bill persists. Data from the National Center for Biotechnology Information shows that approximately 27% of all hospital readmissions are potentially preventable. When you analyze these preventable cases, a distinct pattern emerges. Patients misinterpret their care instructions. Medications never make it home. No one makes a follow-up call. This flowchart illustrates the breakdown in the information handoff. By the time a patient arrives for their first follow-up appointment, only 12 to 34% of hospital discharge summaries have actually reached the aftercare providers. This creates an informational blind spot. The outpatient physician examines a recently hospitalized patient without the critical data required to guide their recovery. The trajectory of a readmission is largely decided in the first 72 hours after discharge. If a patient is confused about their medications or missing warning signs during this window, the likelihood of a return visit spikes. Despite knowing this timeline, 42% of practices report post-discharge follow-up backlogs on a weekly basis. They simply cannot reach their patients fast enough. Readmission prevention is an execution problem occurring at the point of discharge. Solving the crisis requires managing the critical hours and days that follow. A standard post-discharge protocol involves a coordinator calling the patient, reviewing medications, confirming appointments, assessing warning signs, and documenting the entire interaction in the electronic health record. That administrative workload often falls on clinical staff who are already stretched thin. Research shows that 59% of nurses experience burnout, a condition directly associated with inadequate discharge planning. This chart tracks the resulting attrition. Annual nurse turnover sits at 18.4%, while certified nursing assistants reach 41.8%. Replacing lost employees is expensive. Including hiring and training, it costs between $50,000 and $70,000 to replace a single nurse. When a practice cannot maintain adequate staffing, the workload shifts to the remaining team members. This accelerates burnout, which drives further turnover in a compounding cycle. In a high-turnover environment, institutional knowledge degrades. Calls are missed, high-risk cases fall through the cracks, and accountability disappears until a readmission event makes the failure visible. Relying on clinical staff for administrative follow-up creates a capacity trap. It drains the practice's finances while consistently failing to meet the execution requirements of discharge planning. While the cost of staffing an internal follow-up team is high, the clinical impact of successfully executing those calls is documented in peer-reviewed data. This data from a 2023 study across 22 hospitals compares 7-day readmission rates. For patients who were not contacted, the rate was 4.73%. For those successfully contacted, it dropped to 2.91%. Simply completing a structured phone call resulted in a 38% reduction in 7-day readmissions. This aligns with a 2024 CDC meta-analysis of 15 peer-reviewed studies, which found that outpatient follow-up visits reduce 30-day all-cause readmissions by 21%. For specific high-acuity conditions, the results are even more pronounced. This highlight isolates patients with heart failure and acute myocardial infarction. Follow-up within 14 days correlates with a 64% reduction in 30-day hospital readmissions. Achieving these numbers requires strict adherence to protocol. Every patient must be contacted without exception, a standard that teams fighting daily backlogs rarely meet.
For high-risk patients, a 64% reduction in readmission represents a transformational outcome achieved through the consistent execution of a simple follow-up protocol. To bypass the internal staffing bottleneck, a growing number of practices are moving their post-discharge follow-up operations to dedicated outsourced teams. Instead of hiring locally, practices partner with specialized virtual medical assistants. These coordinators plug securely into the practice's existing EHR system to identify and track discharged patients in real time. Because the outsourced infrastructure already exists, a practice can go live in 48 to 72 hours, bypassing the months-long process of recruiting, hiring, and training an in-house coordinator. The virtual team executes the required protocol. They make contact within 72 hours, reconcile all medications, confirm follow-up visits, and screen for clinical warning signs. If a patient reports a warning sign, like sudden weight gain in a heart failure case, the virtual assistant initiates an escalation protocol, routing the patient directly to the practice's clinical staff for immediate intervention. This model isolates the administrative burden. Clinical staff focus entirely on treating patients, while dedicated coordinators ensure the informational handoffs occur reliably. Data consistently shows that a dedicated coordination staff tasked solely with follow-up will reliably outperform clinical teams trying to manage calls between patient exams. Modern outsourced follow-up operates differently than a traditional call center. The difference is the integration of an artificial intelligence layer to manage the workflow. Look at this sorting visualization. An auto-categorization engine reviews incoming follow-up tasks and automatically prioritizes them, separating high-risk patients who need immediate contact from routine cases. As the virtual assistants work, machine learning algorithms monitor the data entry, flagging edge cases or missing information that require supervisor attention before they affect patient care. Simultaneously, an automated compliance system runs checks on every interaction, ensuring all communications and documentation adhere strictly to HIPAA regulations. The foundation of this operation is built on enterprise-grade security, carrying active HIPAA, SOC 2 Type 2, ISO 27001, and HITRS certifications. Practice leadership tracks all of this through a weekly performance dashboard. They see exactly who was contacted, which cases were escalated, and the precise accuracy rates of the virtual team. This AI-assisted layer generates a level of real-time documentation and auditability that manual in-house processes cannot replicate. The primary driver for moving to an outsourced model is the financial reality of the fully loaded employee cost. This chart breaks down the true cost of an in-house hire. Starting from a $35,000 base salary, a practice must add benefits, payroll taxes, training, equipment, and the average cost of turnover. The fully loaded total reaches $60,800 per year. Now, compare that to the outsourced model. A dedicated full-time virtual medical assistant from Staffingly costs a flat $21,600 per year, with all overhead and training included. That represents a 64% cost reduction, yielding $39,200 in direct annual savings for every single coordination position. Beyond the direct savings, this creates a management arbitrage. Practice owners reclaim the hours they previously spent interviewing candidates, managing turnover, and supervising administrative staff. For smaller practices that do not require a full-time coordinator, the model scales down. Tiered hourly coverage is available, ranging from $12 an hour for light support down to $9.50 an hour for full-time volume. Outsourcing converts a high, unpredictable variable cost into a low, fixed operational expense. Post-discharge follow-up is the most effective tool a practice has to keep patients recovering at home and out of the hospital. The peer-reviewed evidence is clear. A structured call reduces 7-day readmissions by 38% and cuts 30-day readmissions by 64% for the highest acuity patients. The barrier to achieving those numbers is a capacity problem, having the staff available to make the calls consistently without burning out. Over 800 healthcare providers across all 50 states have already bypassed this bottleneck by integrating a dedicated virtual team. To prove the model's effectiveness, Staffingly offers a 2-week risk-free pilot. It allows practices to eliminate their immediate follow-up backlog without committing to long-term contracts. If readmission penalties and post-discharge backlogs are affecting your practice, visit staffingly.com/demo or call 800-489-5877 to configure a 48-hour go-live. Solving the readmission crisis depends on closing the execution gap at the moment of discharge.